anemia in pregnancy. See, 50% of the Indian female are anemic, and half of the global death is due to anemia. And 80% of mortalities in Indian subcontinent is because of anemia. In that, 50% is because of anemia. See, we have a definition of anemia as per the CDC guideline and WHO or ICMR guideline. So, as per the CDC, less than 11 gram percent in first and third trimester, less than 10.5 gram percent in second trimester, and less than 10% postnatally is considered as anemia. As per WHO or ICMR, less than 11 gram percent is considered as anemia, and we have a classification of anemia as mild, moderate, and severe, very severe. Mild is 10 to 10.9 gram percent, moderate is 7 to 9.9, severe less than 7, anything less than 4 is considered to be very severe. This very severe is only seen with your ICMR, not with WHO. Okay, so in pregnancy, physiologically, what changes happens in your hematology? Basically, there will be increase in plasma volume by 50%. This leads to hemodilution in pregnancy. Though there is increase in plasma volume, there is also increase in RBC mass by 20 to 30%. Still, there will be decrease in RBC concentration compared to your plasma volume raise, because of which the hemoglobin concentration decreases. This decreases the oxygen carrying capacity. So, the total iron requirement in pregnancy is 1000 milligram. So in that 1500 goes for the RBC formation, because 1 ml of RBC gives rise to requires 1.1 milligram of iron, and we know there will be raise of 450 ml of RBCs in pregnancy. So because of which we need at least 500 milligram of iron, and 300 milligram will go to the fetus, and 200 milligram will be lost through urine, sweat, or stool. So overall throughout the pregnancy we need 1000 milligram. But per day how much is the requirement? That is what we need to know. See, in first trimester the requirement is very less, that is 0.8 milligram per day. Okay, but in your second and third trimester it increases to 6 to 8 milligram per day. Okay, if you take a proper diet, that will give you 5 milligram per day. Understood? So we'll see what are the causes of anemia in pregnancy. In this class, mostly I'll be discussing about the iron deficiency anemia, but we need to know overall causes of anemia in pregnancy. So the overall cause of anemia in pregnancy is, we have divided them as acquired causes and inherited causes. Also you can just divide them as you can divide them as nutritional cause, that is your iron deficiency anemia, vitamin B12 and folic acid deficiency. Then second thing is hemoglobinopathies. If there is any defect in heme synthesis, that is your thalassemia, G6PD deficiency, or hereditary spherocytosis, sickle cell anemia, all this comes in this. And thirdly, anemia due to blood loss. That could be because of your hemorrhoids or worm infestation, where a mother will be losing blood in her stools, or any kind of trauma leading to blood loss. Other thing is a chronic illness that could be seen with your HIV, TB, chronic kidney disease, etc., any kind of infections. Okay, these are the causes of anemia. Also, we can divide them as acquired and inherited causes. Acquired, most common, is your nutritional anemia. Other causes are like your hemorrhagic, anemia of chronic disease, acquired hemolytic disease, aplastic anemia. Inherited, like thalassemia, sickle cell disease, hemoglobinopathies, and inherited hemolytic anemia. So these are the causes of anemia. Now we'll see what are the effects of anemia. Why are we worried so much because of anemia? See, we have a maternal effects and fetal effects. Anytime you are describing any disease or any condition in mother, you should describe the effects of the condition on mother as well as the fetus, because we are dealing with two people in pregnancy. So, what are the maternal effects? See, maternal effects has been divided into antenatal, intranatal, and postnatal. So, antenatally, it can lead to preterm labor, premature rupture of membrane. It can lead to cardiac failure, increased chances of infections, also leads to preeclampsia, antepartum hemorrhage. Then intranatal causes are like your uterine inertia, maternal exhaustion, or bleeding. Postnatally, it can lead to sepsis, postpartum hemorrhage, subinvolution, infections, postpartum depression, poor healing, and venous thromboembolism. These are the effects on the mother. Effects on the fetus, there will be increased chances of low birth weight, fetal asphyxia or hypoxia, preterm delivery, and very severe anemia in fetus, and increases the chances of neonatal anemia by 6 folds also. Now, how do you approach a woman with anemia? See, we'll go by a clinical history. So, we have to know the type of anemia. We have to evaluate a woman and identify the cause and identify the predisposing, precipitating factors. So, history wise, any woman coming to you, usually they don't come to you saying that they have low anemia. They usually come to you with a generalized weakness, headache, and lightheadedness, lethargy. Sometimes they have the syncopal attacks, palpitations, breathlessness, chest pain, symptom wise, and they will have some skin nail changes, loss of appetite will be there, and they will have a history of passage of worms in stools, bleeding from the anal orifices. Sometimes nutritional can also be caused by hyperemesis, chronic diseases, or menstrual history with the heavy menstrual bleeding previously, and obstetric history, any history of previous blood transfusion or iron injections. And sometimes they have a pica is nothing but a craving for a craving for things which are not edible. Okay, so these are by the history. On examination, you will find a palar iron deficiency anemia, severe iron deficiency anemia. You can find the colonychia, which is a spooning of your nails, platynychia, and sometimes nutritional anemic features like glossitis, chelosis will be there. And if anemia is causing a cardiac failure, there can be raised JVP, jaundice, peripheral edema, and leg ulcers, which is most common in sickle cell anemia because of the end artery occlusion. Lymph node examination and lab evaluation. How do we do? Firstly, we get a hemoglobin estimation. Okay, usually we are supposed to do 4 times as per the Ministry of Health and Family Welfare, but at least 2 times has to be done. First visit as soon as they come to you, and second should be 28 to 32 weeks. Okay, anything less than 11 is considered as anemia. If you diagnose anemia, you have to find out the type of anemia. For that, you get a RBC indices, peripheral smear with reticulocyte count, and HB electrophoresis. HB electrophoresis helps you find out thalassemia or sickle cell anemia. Okay, and these RBC indices are also very important. So in that we have MCH, MCV, MCHC. So everything is decreased, then that tells you it's a iron deficiency anemia. But if there is increase in MCV more than 100 femtoliter, that tells you it could be because of the folic acid deficiency or vitamin B12 deficiency, liver disorders or hypothyroidism. So microcytic anemia is also seen with your iron deficiency anemia, thalassemia, and anemia of chronic disease. So how do you differentiate between anemia, iron deficiency anemia and thalassemia? You have something called as Mentzer's index. Mentzer's index is MCV by RBC count. Anything more than 13 is iron deficiency anemia, less than 13 is thalassemia. Also, there are other things from which you can diagnose iron deficiency anemia. So, coming to the iron deficiency anemia, which is the most common cause of anemia in pregnancy, we have a 3 stages of iron deficiency anemia. See, first stage is just decrease in serum ferritin level. So here the stores get depleted, serum ferritin is decreased, but there is no anemia in them. Okay, it's just a biochemical parameter which is decreased. Second stage, there will be depleted erythropoiesis, and this important thing is there is increased TIBC, and transferrin saturation will decrease. Transferrin saturation is serum iron by TIBC. Here also the hemoglobin is normal, still there is no anemia. These are the stages. Once there is decrease in hemoglobin and peripheral smear is showing microcytic hypochromasia, along with that iron stores are depleted, then that is your iron deficiency anemia stage. Okay, so coming to the serum ferritin, the normal value is 20 to 200 microgram per liter. So anything more than 100 microgram per liter tells you that the stores are normal. If it is less than that, we can think that there is depletion in the store. Though there is no anemia, the stores are depleted. So you have to take a action now to improve the store. Okay. So stage 3, which I told you, there will be less hemoglobin. Along with that, serum iron is less than 40 microgram per deciliter. And total iron binding capacity is increased. The normal value is 300 to 400. Anything more than 400 tells you iron deficiency anemia. The transferrin saturation, that is serum iron by TIBC, normally it is 25 to 50%. If it is less than 10%, says it is iron deficiency anemia. One more thing, serum hepcidin level, it is decreased in iron deficiency anemia and increased in chronic disease. Why is it decreased in iron deficiency anemia? Because there is already deficient iron in the body. So the body needs iron. Hepcidin is the one which prevents absorption of the iron. So if the iron itself is low, then the hepcidin levels goes down as a feedback so that the iron is absorbed more. Okay, and in chronic diseases it is going to increase because it acts as a inflammatory marker. So how do you differentiate iron deficiency anemia and chronic anemia due to chronic disease? One thing is your serum hepcidin level. Okay, and they can give you a case scenario where they say serum hepcidin is high, serum hepcidin is low. So that is how you should differentiate. Now there are some advanced tests as well. So something called as free erythrocyte protoporphyrin. So this free erythrocyte protoporphyrin is increased in iron deficiency anemia. And second is soluble serum transferrin receptors. This is the most sensitive than your serum ferritin for iron deficiency. But the thing is, it is expensive, so we cannot do it in everyone. Okay, The soluble serum transferrin receptor STFR. Now, zinc protoporphyrin will be increased. Bone marrow biopsy should be done in refractory anemia. If there is no stainable iron in bone marrow, which is the gold standard diagnosis for iron deficiency anemia. Okay, this is how you evaluate for iron deficiency anemia. So now we'll come to prophylactic treatment. Prophylaxis is different from treatment, okay? Prophylaxis is given for everyone, irrespective of the anemia status. So why do we give this? Because we know pregnancy itself is a condition where the iron requirement is increased. So if we don't supplement it, obviously they're going to have an anemia later. So to prevent that, Anemia Mukt Bharat, which is an integrated national iron plus initiation. So it as a 6 by 6 by 6 strategy. So there are 6 beneficiaries, there are 6 interventions and 6 institutional mechanism where these interventions are carried out. So what are the interventions? So there is a hemoglobinometer which checks the anemia status. There will be prophylaxis for iron with iron and folic acid supplementation. Deworming will be done. Delayed cord clamping, food fortification, and other causes of anemia identification. So coming to the prophylaxis, as I told, we need at least 6 to 8 milligram of elemental iron. But tell me, how much of the elemental iron is absorbed? 10% of elemental iron is absorbed from whatever we take. So that is why if we need 6 milligram, then we have to take more amount. So as per this Anemia Mukt Bharat, what they give is a 60 milligram of elemental iron with 500 microgram of folic acid daily. So if you are planning for pregnancy, you can stop iron folic acid and take folic acid supplements daily with preconceptionally and in first trimester. After first trimester, you can continue iron folic acid pill per day at least for 180 days antenatally and 180 days postnatally. So this iron folic acid has to be taken 1 to 2 hours after food or at least half an hour before food. See, before food taking has some disadvantages of causing gastritis and all. That's why we don't usually say, but if people are compliant with the iron folic acid taking before food, then they can just continue taking that. But the reason is vitamin C or the acid content of the stomach is more and it increases the absorption of the iron. It's not in the stomach but in the duodenum where the iron gets absorbed. So along with that, we give a deworming mandatorily to all pregnant women with 400 milligram of albendazole 2 times per year every 6 months. Okay, so before that, I'll just tell you about how the iron is absorbed in our body. So see, this is a intestinal lumen and this is a food which has a iron. Iron will be in two forms, ferrous and ferric form. The ferrous form is the one which gets absorbed. Okay, there is a heme transporter which absorbs the heme or iron. So this heme oxygenase helps in transporting the iron from the lumen to the intestinal lumen to the cell, and this ferrous form passes to the blood vessel with the help of ferroportin 1. Okay, if there is a ferric form, this ferric form gets converted by duodenal cytochrome B to ferrous form, and again this ferrous is absorbed inside the lumen of the intestine using divalent metal transporter 1. So some of them get stored in the intestine itself as mucosal ferritin, and usually they are lost by shedding of epithelial cells. Okay, so the remaining iron goes inside the blood vessel, and this ferrous form is converted to ferric by hepastine in the blood vessel lumen. Okay, this binds with the transferrin and goes and stores in the storage areas. So hepcidin is the one which inhibits this ferroportin. As it inhibits this ferroportin, there is no absorption of the iron from the intestine to the blood vessel. So when this hepcidin is secreted, whenever the storage is more, the liver secretes this hepcidin and stops iron absorption. Okay, this is a physiology of iron absorption. Now I'll just talk about the treatment of iron deficiency anemia. See, prophylaxis we give only one tablet per day, but in treatment we have to give 2 pills per day. And the HB starts raising after 2 weeks at 0.7 gram percent per week, or it takes at least 3 weeks to 4 weeks. Okay, to raise HB by 1 gram percent. Okay, this is also there will be reticulocyte count increase after 7 to 10 days, which is a marker of improvement. First marker is improvement of symptoms, second is your reticulocyte count, and third is your hemoglobin level. So when do you say there is inadequate response? If HB is not increasing by 1 gram percent or less than 1 gram percent after 4 weeks, then we consider it as inadequate response. So this inadequate response could be because of the non-compliance or intolerant to the salt whichever we are giving. So if you find there is intolerance or non-compliant, you can change the salt of the iron like ferrous sulfate or ferrous fumarate or ferrous gluconate. Okay, still not, then you can go for parenteral iron therapy. So where we give it in non-compliant, intolerant, severe anemia in early third trimester, that is your less than or equal to 34 weeks, and mild to moderate anemia in late trimester, third trimester, that is more than 34 weeks. So how do you calculate that this person needs this much of parenteral iron? For that we have something called as Ganzoni's formula. The iron requirement is calculated by 2.4 into hemoglobin deficit. Hemoglobin deficit is the required hemoglobin subtracted by the amount of hemoglobin the person has. That gives you deficit. And you have to multiply it by pre-pregnancy weight. Weight at first visit you can consider. If woman is obese, ideal body weight to be considered. Okay, with 500 milligram for storage. So if weight is less than 35 kg, you can calculate by 15 milligram per kg as well. So this is your Ganzoni's formula. Depending upon this, you will calculate the amount of iron required. So example, I will take a woman now with a HB of she's having some 8 gram percent. Okay, and her pre-pregnancy weight was we'll consider it as 25 pre-pregnancy weight. So she is little low weight. So now we have to calculate. I will go by this 15 mg per kg, okay, for storage. So what I will do, 2.4 into what is the hemoglobin deficit in her. So we consider 11 gram as the cutoff. 11 minus 8 is 3 into pre-pregnancy weight is 25. Now we need to have stores. So I will consider 15 mg per kg. She was 25, so I will give it as 15 by 25, that is This is not multiplication, this is just a addition of plus 375 grams. Okay, so now we'll calculate it. 2.4 into 3 into 25, this comes out to be 180 plus 375, which is 555. Now I have to give this woman 555 milligram of parenteral iron. So we have different generations of parenteral iron, first, second and third. First generation is outdated now, we don't use it, which is iron dextron, which we used to give it by a ZERD technique. It had its own side effects, certain anaphylactic reactions and also skin reactions, so we have stopped using it. Second generation, we have iron sucrose, which is less anaphylactic. Third generation is ferric carboxy maltose, which is compared to others least anaphylactic. Okay, so now in the peripheries and all, mostly they use iron sucrose. So this iron sucrose, one vial as 5 ml of iron sucrose, and each ml contains 20 milligram of iron sucrose. So that means one vial will have 5 into 20, 100 milligram of iron sucrose. So we have to give 200 mg per day. Okay, so for that we take 2 vials in 100 ml of NS, which has to be given in 15 minutes, 10 to 15 minutes. Okay, so it has to be repeated every alternate day, and maximum dose what you can give in a week is 600 milligram per week. That means you can just give 3 doses in a week, not more than that. So if my patient needs 555, I can just give her 3 doses and leave it. Okay, it has to be given slowly, 20 to 30 drops per minute in 5 minutes. The T half is 5 to 6 hours. So give IV flush before and after the procedure so that it gets absorbed. Okay, so if there's history of anaphylaxis, or if she's having anaphylaxis, stop oral. You should rule out the history. And what are the prerequisites before you give iron sucrose or ferric carboxy maltose? You have to stop oral iron 1 day before till 4 weeks after injection. Why do we do that? Because see, if oral iron is given, then it occupies the areas where the iron has to get stored, and injectable iron will be free and it just reaches the organs and leads to side effects. So if you want the receptors to be free, then stop the oral iron and don't give it after 4 weeks till 4 weeks. Okay, if women is developing a anaphylaxis reaction, then you give a avil injection 2 ml, hydrocortisone 100 mg, or adrenaline 0.5 ml 1 in 1000 dilution. Okay, so ferric carboxy maltose, this has a least anaphylactic reaction compared to anything. So you can give maximum dose of 1000 mg per day. Okay, so if my patient needed only 550, sometimes if there is 1500 ml 1500 mg, then you can give 1000 mg in the first sitting and the next dose to be repeated after 1 week. Okay, remaining whatever dose is there, we can repeat after 1 week. So this one vial as 10 ml, which equalizes to 500 milligram of iron. So if you need 1000 mg, we have to take 2 vials, which has to be diluted in 100 ml NS, given over 15 minutes. So the common side effects will be like headache, dizziness, nausea, constipation and all, and injection site reactions can be there. So Where we don't give parenteral iron, in if there is history of allergy, hemochromatosis, thalassemia major, acute infection in body is a contraindication for parenteral iron. Okay, so with parenteral iron the HB increases by more than 2 weeks or 3 to 4 weeks. Okay, retic same as more than 7 days. Now this is about parenteral iron. But when do we give blood transfusion? Anytime in pregnancy, if hemoglobin is less than 5 gram percent, you have to transfuse blood. If hemoglobin is less than 7 gram percent and women is more than 34 weeks, then you have to give blood. Impending heart failure, like she is having cardiac failure features, then you have to give. If there is hemodynamic instability with severe anemia, you have to give. Acute hemorrhage with severe anemia, you have to give. Bone marrow failure, you have to give. Thalassemia major, you have to maintain a target of at least 9 to 10 gram percent. Okay. Now anemia of chronic disease, which I told you could be because of the HIV, TB, cancer, rheumatoid arthritis, all these things. So here there will be low iron, ferritin will be normal or increased because of acute inflammation. The total iron binding capacity will be low. Serum transferrin saturation is normal or increased. Hepcidin will be high. So here you have to correct the cause. Okay, you can give recombinant human erythropoietin 4000 international unit subcut 3 times per week for 4 weeks. Then the other cause, megaloblastic anemia, which is caused by iron and vitamin B12 deficiency. They help in nucleic acid synthesis and also DNA synthesis, associated with the leukopenia and also thrombocytopenia. So what are the causes of this megaloblastic anemia? Could be because of diet, hyperemesis, alcohol or smoking. So this folic acid vitamin B12 deficiency causes abortions, neural tube defects, abruptions and prematurity. The diagnosis is by peripheral smear, which shows macrocytes, hypersegmented neutrophils, and I already told MCV will be more than 100 femtoliter. Folate level will be low, and LDH will be increased because of hemolysis, and homocysteine will be increased. So prevention, WHO recommends 400 microgram per day, 1 month prior to pregnancy and in first trimester as well. So if history of neural tube defects is there in the past pregnancy, you have to give 4 mg 3 months before pregnancy. What we get over the counter is 5 mg pill, so the same thing we give. Okay, the response is seen by decrease in LDH in 3 to 4 days, increase in retic count by 7 to 10 days. Therapeutic dose is 1 mg. So if there is a B12 deficiency, then you have to give 1 mg IM 3 times per week for 2 weeks. 3 times per week could be alternate day. So if I give on day 1, next I give on day 3, next I give on day 5. This is for 1 week. And I repeat this for 2 more weeks. Understood? What we give for B12 deficiency. Okay, this is about nutritional anemia mainly. There are other causes like thalassemia and all, which we will discuss later.